All right, here we go again with the urinary system. So with our urinary system, what we really want to think of is it is a filtration system. What we're really doing with our urinary system is cleaning the blood, and the kidney is just the main component behind that. It is the driving force behind the entire system and is doing by far the majority of the work. And so the biggest portion of this chapter, we're going to be looking at the kidney and all of the stuff that it does and how vital it is to our survival. So with our urinary system, we are talking about 2 kidneys, 2 ureters, a bladder, and a urethra. 2 kidneys, 2 ureters, 1 bladder, and 1 urethra make up your entire urinary system. So each kidney is going to measure about 3 centimeters by 6 centimeters by 12 centimeters. Our right kidney sits just a little lower because the liver is going to occupy the space that is above it. So it only has so much room before it hits the liver. So our left kidney we find at about the level of T11. The right kidney we're going to find at about T12. Remember, T12 is our last thoracic vertebra. The lumbar vertebra L1 starts right up underneath that. So we're pretty far down in the low back before we get to the kidneys. And speaking of which, our kidneys sit as far posterior as we can really get. They're behind all of our digestive organs, behind all of our vessels, behind all of that other stuff, kind of tucked in right up against the ribs at the very, very bottom. And the ribs that we're tucked up against are the floating ribs. And if we remember the floating ribs, they're short, little, jagged ribs. So they don't do a great job at protecting our kidneys. So our body has kicked in and has surrounded the kidneys with this extra layer of fat to help hold them in place and to protect them, since the floating ribs aren't doing a very good job. This layer of fat we refer to as the perirenal fat because it covers the kidneys. And this is a type of structural fat. So we have functional fat in our body, and we have structural fat. The functional fat is our dietary fat. That's the kind of fat people think about. That's your beer belly kind of fat. Where our structural fat, also known as our visceral fat, is a different kind of fat that we use as an extra layer of protection around some of the big important organs in our body. The heart, the liver, the stomach, and the kidneys fall into that category as well. So we use it for protection, and we also use it to just anchor everything in place, especially the kidneys. We use this layer of fat to help hold the kidneys where we want them to be. But we do see in extremely malnourished patients and also in marathon runners where we've burned through all of our reserves of functional fat, and when we have no more functional fat, then your body will turn to the structural fat and start breaking it down as an energy source. And so with marathon runners in particular, they're just super lean. They have almost no functional fat left in their body, so their body burns the structural fat, and then they start having kidney issues. And what has happened is their kidneys are basically floating around inside of their abdomen at this point because they've broken loose from the structural fat, what little bit remains, because they've burned the rest of it up. So that's just something to be aware of if you ever meet a marathon runner who's having, kidney issues. Be like, hey, you need to check your structural fat. All right, let's just keep going. So I said the kidney acts as a filter, and that is its main job, but it actually does a lot for us. And it plays a role in several different key factors. So we use the acronym a wet bed to help us remember some of the more important things that the kidney actually does. So a wet bed, we can see how it's broken down here, and we're going to go through each of these individually. So A stands for acid-base balance. And with acid and bases, we're talking about the pH scale, of course. And we want to remember that our normal blood pH is 7.35 to 7.45. And so to help us keep within that range, the kidney can actually excrete any hydrogen ions or hydroxide ions depending on our body's needs at that particular moment. So we can either keep the hydrogen ions if we're too basic, or we can get rid of the hydrogen ions if we're too acidic, or we can keep the hydroxide ions or get rid of the hydroxide ions, just depending on what's coming through the kidneys to help us keep within that 7.35 to 7.45 range. W for water volume particularly. So the kidney just plays a big role in maintaining how much water we keep in our body depending on our hydration levels at any given time. We can produce more urine as we need to if we have too much water, or we can pull the water back out of the urine and just urinate less if we need to hold on to that due to our hydration levels. E is for the electrolyte balance. So remember, with electrolytes, we're typically talking about ions. And so we can see that here with sodium ions, chloride ions, potassium ions. Those are probably the big ones that we want to get back into the bloodstream. And just so we're clear, an electrolyte is a chemical that can conduct electricity in water. Ions have that charge already, so they are going to be classified as electrolytes. T for toxin removal, and this is the filter component that we said was the kidney's main function. B for blood pressure, where the kidney, again, talking about the fluid volume, the water volume in particularly, is going to have an impact on blood pressure. Now, the kidney does also produce an enzyme called renin that helps maintain fluid volume. And while we're talking about the kidney producing renin, the kidney also produces erythropoietin. So our next letter is E for endocrine. And with this one, erythropoietin, this is the hormone that's made by the kidneys that we're going to use to produce red blood cells in our bones. And we talked about erythropoietin a little bit in our blood chapter. We're coming back to it now. To complete that circle. Ugh. All right, D for vitamin D activation. So when we activate vitamin D, we don't call it vitamin D anymore inside our body. Now we call it calcitriol. And once it does get activated, it helps us regulate calcium and phosphate balance for healthy bones, because we need those healthy bones, because that's what's using the erythropoietin to produce the red blood cells. There we go, full circle. Moving on. All right, the structure of a kidney. So the first thing we're going to notice about a kidney is it has a renal capsule. This is just an outer protective layer that we're going to find underneath the perirenal fat. Then we have the renal hilum, and just like the lungs or some of our other organs, it's the only way in or out of the kidneys. You got to go through the hilum. The rest of it is enclosed in that renal capsule. Now, if we were to do a cross-section of the kidney, what we're going to see is two distinct reddish areas. We have a lighter red area we refer to as the renal cortex, and we're going to find this around the perimeter. For the most part, it does jet into the middle a little bit. And then the renal medulla is the darker red area that forms these little triangles that all kind of point towards that renal hilum. All right, so if we look at the renal medulla first, we can see in our picture down here at the bottom the little triangle shape. We refer to these as renal pyramids. Renal pyramids, and the kidneys can have anywhere from 7 to 18 renal pyramids. Now, the point of each pyramid we refer to as the renal papilla. The renal papilla, that is the apex, the tip, pointed back towards that renal hilum. And this is going to help us move our urine into the calyces. It's also where we're going to find our papillary duct. So let's make that association. The renal papilla, the papillary duct. And then a renal lobe consists of one of the renal pyramid and its overlying area of renal cortex and half of each adjacent renal column. So what that means is we've got the entire renal pyramid, and then we also get the lighter red area at the base of each pyramid and half of the lighter red area that runs along the side of each pyramid. And that constitutes one renal lobe. So our renal cortex, this is the lighter area. It extends from the renal capsule to the base of the pyramids and the spaces in between them. We call the space in between the renal pyramids the renal columns. So the renal columns are actually renal cortex. The renal pyramids are renal medulla. I think an easier way to think about this, the renal pyramids are the renal medulla. Everything else is renal cortex. Everything else is renal cortex. All right. The nephron. So the nephron is the functional cell of the kidney. This is where all of the magic happens in the process of making urine. Each kidney has about 1 million nephrons, and each nephron has two main parts to it. We have a renal corpuscle, which is the little ball-like contraption at the top, and then the long, tangled renal tubule that follows after that. So let's start with the renal corpuscle first. What I want you to know is this is where blood plasma is actually filtered. This is where we're actually going to start the process of making urine in the renal corpuscle. Now there's two parts to our corpuscle. We have the glomerulus, which in Latin means a ball of yarn. And that's really what it looks like, a small, tangled capillary network that is just in this big ball. We branch these vessels and branched them, and now these are as small as we can get, and we've kind of tangled them all up and put them inside in this little ball. So we're going to think of it as a ball of capillaries. That's our glomerulus, a ball of capillaries. Now completely surrounding this ball of capillaries is our glomerular capsule. It's also known as the Bowman's capsule. And it's just a little cup-shaped structure that's going to collect anything that gets filtered out as we start to push things through this glomerulus. The second part of our nephron is the renal tubule. And this is where we're going to pass anything that we filter so we can start making its way out of the body. So we have three parts to the renal tubule. So in our picture here, we can see that glomerulus right in the middle, that ball of capillaries, and surrounding it is that Bowman's capsule to collect that fluid. Then we move into the actual renal tubule, and the first thing we come to is the proximal convoluted tubule. So convoluted just means tightly coiled, so as soon as we leave the glomerulus, we have this tangled part of the tubule. From there, we move into the loop of Henle. We have a descending side and an ascending side. And then, lastly, we move into the distal convoluted tubule. So another little tangled section with our renal tubule. So we just term it proximal and distal based on its attachment to that glomerular capsule or to that Bowman's capsule. So the proximal is going to be closer to the Bowman's capsule, where the distal is going to be farther away. So my distal convoluted tubule of several nephrons are then going to empty into one collecting duct. So we got one collecting duct draining several nephrons. The collecting duct is then going to funnel its contents into the papillary duct. And again, this is found at the tip of our renal pyramid at the renal papilla. Our papillary duct is then going to empty into the minor calyx. So a minor calyx we find just past that renal papilla of each of our renal pyramids. It's going to drain any filtered solution out of the pyramids through the papillary duct and into a major calyx. So our minor calyx is like a little funnel collecting everything that's getting pushed through that papillary duct as it leaves the renal medulla. Our major calyx, this is where we get several minor calyxes all draining together. So each kidney is going to have 8 to 18 minor and just 2 to 3 major calyxes. So we need several minor calyxes to make one major calyx. And then all of our major calyxes are going to drain into this big single cavity right in the middle we call the renal pelvis. And that's going to drain to our ureter as our solution, our fluid here, is going to leave the kidney. So that's our pathway out of the kidney. So we can see in our picture all of the renal pyramids going all the way around. And at the base of each pyramid, we can see the minor calyx. We have one minor calyx at the base of every pyramid. And then where there's a region where there's several minor calyxes coming together, that's going to be a major calyx. And we can see we don't have major calyxes all the way through. We just have them where several minor calyxes are coming together. Then our renal pelvis is going to be kind of in the middle of the kidney, close to the hilum, because that's our way out. So we've kind of drained everything towards the exit. And then our ureter is going to collect all of that stuff and send it towards the bladder. All right, blood supply of a nephron. So we said that the kidney's main job is to filter the blood. So we got to talk about the blood supply and how it actually gets to the kidney. Now I know on the right-hand side here, that's our pathway. We want to know that. We want to know that in order. And I know it looks a little overwhelming at first, but the first four things and the last four things are really the exact same. It's just we exchange artery or vein as we make our way through. So blood flows through the renal artery into our interlobar artery because it runs in between the lobes. Then it's going to go up into the arcuate artery. And then our arcuate artery is where we're going to make a turn. Then we go the cortical radiate artery because we're up into the renal cortex at that point. Then we go into an afferent arteriole leading into the glomerulus. So our glomerular capillaries, that is the glomerulus, that is the tangled ball of capillaries. Then blood flows out of the glomerulus, out of that capsule, through an efferent arteriole, where it's then going to surround pretty tightly the renal tubule. And we refer to this as our peritubular capillaries. And we can see that in our picture on the left, how the peritubular capillaries just wrap around that renal tubule. And that's going to be important coming up. And then we're on our way out, so we get pushed into the cortical radiate vein, the arcuate vein, the interlobar vein, and out the renal vein. So this is a pretty good picture showing how all of the blood supply to the kidney gets broken down into its individual sections. We can see coming into the renal artery, we've got our segmental arteries, how the vessel essentially just segments out and spreads out. Our interlobar artery, we can see how that runs in between the renal lobes specifically. We find it in between the pyramids. Remember, each lobe has a pyramid in it. We got our arcuate artery, where it splits again and turns around the top of the renal pyramids. The cortical radiate arteries radiate straight out into the cortex. And then our afferent arterioles branch off of that and lead into the glomerulus of a nephron. So another picture here, just kind of helping break down everything that we've gone over thus far. We can see how the nephrons are laid out mostly in the cortex, but that loop, the ascending and descending loop, drops down into the medulla. All right, so now that we know the parts of the kidney and we know the blood supply to the kidney, we've got to talk about the formation of urine. So the formation of urine happens in 3 steps. The first step is the glomerular filtration. So we're going to send blood through that tangled ball of capillaries, through the glomerulus, and we're going to use blood pressure to force water and most of the solutes in our plasma across this filter made by the glomerular capillaries. We're going to push this fluid across this filter and into that glomerular capsule, or into that Bowman's capsule that is going to collect all of this solution and send it into the renal tubule. So the first part, glomerular filtration, happens at the glomerulus. That would make sense because it's glomerular filtration. But that's all we're doing is we're pushing the fluid portion of blood across this filter into the space. From there, we're going to move on into tubular reabsorption. And just so we're clear, part 2 and part 3 happen at the same time in this process. So as we're sending the solution through the renal tubule now, we have tubular cells that are going to reabsorb a lot of the useful stuff that we want and return it back to the blood. We're like, well, we didn't mean to filter that. Let's grab that and put it back into the blood. At the same time, tubular secretion is happening, where anything that didn't get filtered out of the blood, we're adding to the tubule by other tubule cells. Like, we meant to filter this. Boom, let's add it to the renal tubule. All right, so let's look at these in a little bit more detail. So our first step we said was glomerular filtration, where we're using blood pressure to push our fluid through the filter. So we're going to look at the filter here that we're actually talking about. So the first one is called fenestrated epithelia. So fenestrae is just holes in Latin. And we can see in our picture here how the capillary of our glomerular capsule has all these little tiny holes in it. Each of these holes is going to measure about 70 to 100 nanometers. And really what this is stopping cells from getting filtered. We don't want to filter entire cells. What we're trying to do is just get the trash products out of our blood, not the actual blood cells. So we're going to let the blood cells pass on by, and we're going to just try to grab the fluid. But that's what our fenestrated epithelia does, is it stops cells from getting filtered. So we said these holes measure 70 to 100 nanometers. So for reference, if we take 1 meter, that's 3 feet, divided by 1,000, that's going to be 1 millimeter. If we take one of those millimeters and divide it by 1,000, that's going to be a micrometer. If we take 1 micrometer and divide that by 1,000, then that's going to get us to a nanometer. So absolutely minuscule, tiny, tiny little openings here. But they are what is going to stop cells from making it into our urine. All right, so the next thing with glomerular filtration is we have a collagen basement membrane with these vessels. And the collagen is negatively charged. Most of our proteins and ions are also mostly negatively charged. Like charges repel each other, so this stops proteins from being filtered. So our collagen basement membrane stops proteins from being filtered. And then our third component to glomerular filtration are the podocytes. So podocytes are these weird little cells that kind of wrap around the glomerular capillaries. And they have these little branches that jut out from them called pedicles. And these pedicles form these little slit-like openings that measure anywhere from 10 to 40 nanometers. So they're even smaller than the fenestrae. Small enough that they are able to stop plasma proteins from being filtered. We certainly don't want to do that. We want those proteins in our blood because they serve a major function in osmotic pressure, transport of lipids, etc. So we want to keep those plasma proteins in our bloodstream at all costs. And that's what the podocytes do for us. So if we look at our picture here, we've got a really good shot of what one of these capillaries looks like in our glomerular tangled ball of yarn capillaries. So the first thing we want to look at on the left-hand side near the bottom are the little holes. That is the fenestrae, and that's what's stopping any cells from getting pushed out of our bloodstream into that glomerular capsule. Then we have our glomerular capillary with the basement membrane in the bottom left-hand side. So that is just basically showing our basement membrane that is negatively charged to stop our proteins from being filtered. And then we can see the podocytes, nice big nucleus on those podocytes, and we see how they kind of just wrap around and completely envelope the glomerular capillary. And then the little branches, the little podocytes jutting off of it, give us those little slit-like openings, which is enough to stop any plasma proteins from actually getting filtered. So that's step one. That's the filter. We got fenestrae, we got the collagen, and we got our podocytes / pedicles. They're stopping cells from being filtered. They're stopping proteins from being filtered, and they're stopping plasma proteins from being filtered. The next step in urine formation, tubular reabsorption. And remember, step 2 and step 3 are happening at the same time. So as this fluid now gets pushed through the glomerular capsule and into the tubule, it's going to make its way through the tubule towards the collecting duct where all of this is happening. So tubular reabsorption, step number 2. This is where our tubular cells reabsorb water and many of the useful solutes and return them back to the blood. So this is the stuff that we didn't really want to get filtered. This is stuff we're going to pull back in. A lot of water. Most of the water gets pulled back and put back into our blood. A lot of ions and bicarbonate, that kind of stuff, all gets put back into our blood because we want to keep that stuff. That's useful stuff to us. So what exactly does the body reabsorb? So we leave the glomerular capsule in our picture here, and we see the first thing we get into is the proximal convoluted tubule. And this is where most of the reabsorption occurs. And specifically, we're pulling back any sugar if we want it, various ions, HCO3, that is bicarbonate, and then water. We're pulling all of that back in through the proximal convoluted tubule. From there, the fluid is going to move into the loop of Henle. And with our loop of Henle, we are really focusing on reabsorbing water. We want to get as much water back as our body wants/needs. And the longer the loop, the more time we have to reabsorb the water. And the more water we reabsorb, the more concentrated our urine becomes. So once we come back up the ascending limb of our loop of Henle, we then move into the distal convoluted tubule. And with this one, we're really looking at any ions that we still may want, any bicarbonate that we haven't already grabbed, and any water. If there's anything left, we want to grab it in the distal convoluted tubule. And then by the time things get to the collecting duct, there's not a whole lot left. We've reabsorbed pretty much everything that we want. So just 5% of the reabsorption occurs in the collecting duct, and this is just the last-ditch effort to catch any ions, specifically sodium chloride, and any bicarbonate that has made it past the other reabsorptive processes. So step 2, we're reabsorbing, but it's really focused on water, bicarbonate, ions, and glucose. Let's reabsorb that stuff. Step 3, tubular secretion. So this is where our tubule cells add other waste products and solids to the fluid left inside the tubule. So as we're pulling stuff out that our body wants, we're also putting stuff in that didn't get filtered out. Stuff that still ended up in our blood. We're like, wait a minute, we meant to filter you. We don't know how you got past the filter, but let's go ahead and add you to the tubule now so we can get you out of the body. All right, so anything that's left then drains into the renal pelvis, and we now can call it urine, and it gets excreted. So cardiac output, if we remember from our heart chapter, the heart pumps about 5 liters of blood every minute. 20% of that goes straight to the kidneys, which is just crazy if you think about that. 1/5 of what your heart pumps, every time it pumps, 1/5 of that goes to your kidneys for cleaning. The other 4/5 continue the function of the blood cells as far as transporting gases and phagocytizing, all of the blood cell functions. The other 4/5 are doing that. 1/5 of it has to go through the cleaning process. So that means 1 liter per minute of blood is getting pushed through the kidneys. Of that, about 120 milliliters of fluid actually get filtered every minute by the kidney. 99% of that is going to get reabsorbed, put back into the blood, but that's still a lot. And we're going to pee out about 1% of that. So we're going to pee out about 1.8 liters of urine a day. I got to fix that. 1.8 liters of urine a day. All right. And then when we look at the whole process here, this is a great picture. Know this picture. It breaks down all of the components of the kidney on the left, and then on the right it shows us the pathway of urine formation, starting with the nephron, going all the way down through the ureter towards the urinary bladder. Know this picture, left, right, backwards, and forwards. All right, so once we leave the kidney, we move into the ureters. Our ureters transport urine from the renal pelvis to the bladder. So they're just little segues, little pathways to get the urine out of the kidney and stored in the bladder until we're ready to urinate. Each of our ureters is about 10 to 12 inches long. Urine flows by peristalsis, which we remember as the wave-like contractions. Hydrostatic pressure and gravity all help move urine down the ureters towards the bladder. We get a physiological valve that prevents backflow of urine back up into the ureters by compressing the opening of the bladder as it fills with urine. It kind of closes off the ureters there. We also get some goblet cells that secrete a mucus to help protect the ureters from the urine that they are transporting, because urine is toxic to our cells. We don't want it to come in contact with it because it will cause irritation, and over time that could be a big problem. So we use our goblet cells to give us a little mucus barrier to help protect the ureters. From there, urine is going to flow into the bladder, which is a hollow, distendable organ in the pelvic cavity. When it's empty, it collapses like a deflated balloon. As it fills, it becomes pear-shaped. The urinary bladder is smaller in females because the uterus is right above it. So females just don't have as much room in their abdomen, so they have a smaller bladder. We have a transitional epithelia that makes up our bladder, which means it is stretchy, so it can expand and relax. We get some ruga to help permit further expansion as the bladder fills. Our muscularis of the bladder is 3 layers of smooth muscle. We call it the detrusor muscle. So the muscularis of the bladder is the detrusor muscle. And we have this little interesting region near the base of our bladder called the trigon. It's a little triangular area with a smooth surface that allows urine to funnel down into the urethra as the detrusor muscle contracts. We just change it to a nice, smooth little area of tissue that's going to be easy for urine to flow down. So the trigon is made up of my 2 ureteral openings and my 1 urethral opening. Those three areas make up the corners of my trigon to give it that triangular shape. All right, the urethra, a small tube that leads from the internal urethral orifice in the floor of the urinary bladder to the external urethral orifice for discharge of urine outside of the body. So we have 2 sphincters there. So what that means, we have an internal urethral sphincter. That one's going to be smooth muscle and is involuntary. Then we have an external urethral sphincter, which is skeletal muscle and is voluntary. The micturition reflex, discharge of urine from the urinary bladder into the urethra. This occurs through voluntary and involuntary muscle contractions. As the bladder contracts, both sphincters relax and urination is allowed to take place. Now, urination is a reflex, but we are taught in childhood to initiate it and stop it voluntarily. So if we look at the urethra in females first, it's relatively short. It's just 1.5 inches with an exterior opening between the clitoris and the vaginal opening. We can see in our picture on the left there. With males, it's longer. It's about 8 inches long. We also use it to discharge semen with our reproductive system. We subdivide our male urethra into 3 regions. Depending on what it is passing through. That's all it is. What is it passing through? So we have our prostatic urethra that passes through the prostate, the membranous urethra that's going to pass through the deep muscles of the perineum, and then the spongy urethra actually passes through the penis itself. So urine composition is going to reflect the volumes of water and solutes the kidney has to eliminate to maintain homeostasis. It varies from time to time, but typically it's going to be about 95% water. It's usually going to contain urea, uric acid, and creatinine. There may be trace amounts of amino acids, a few electrolytes, and of course all of this varies depending on how much you're drinking and other environmental factors. So let's talk about some pathologies of the urinary system, just a couple. A urinary tract infection, a UTI. This is typically when we get bacteria somewhere in our urinary tract. Most often it's going to be in the urethra or even up into the bladder. Its symptoms: you get a strong, persistent urge to urinate, a burning sensation while urinating, passing small, frequent amounts of urine, and in women we can get a centrally located pelvic pain. So the risk factors really for women is just they have a shorter urethra, which means that there's just a shorter distance that bacteria have to travel to actually get to the bladder and cause a UTI to take off. Sexual activity, diaphragm, menopause also make people more vulnerable to getting bacteria. Kidney stones or nephrolith. Typically composed of minerals or salts, diet, excess body weight, medications, supplements, several different causes. We can see in our picture, I've listed just 4 different types of kidney stones. These are probably the 4 most common types of kidney stones, and that's really the first step. If you're someone that gets kidney stones, you know someone who has problems with kidney stones, and you got to figure out what kind of kidney stone you have so you can start taking the necessary steps to prevent them from reoccurring. So with kidney stone symptoms, we're talking severe sharp pain in the side and the back, pain that can radiate into the lower abdomen or the groin. It comes in waves and fluctuates in intensity. There also can be a pain or a burning sensation while urinating. Passing the kidney stone is painful, and it's really the most painful part is just getting out of the actual kidney itself. There's just not a lot of room. We got to make its way through the actual kidney. But once you get past that, it's typically not nearly as bad. Treatments range from painkillers to surgery, depending on the severity or the size of the kidney stone. Right, urinary incontinence, the loss of bladder control. So this is you pee when you don't really mean to or want to. With coughing, sneezing, especially as you age, tends to happen more often. For the most part, we see this in elderly women due to weaker pelvic floor muscles that just allows that urethra to leak. Chronic kidney disease, aka kidney failure, the gradual loss of kidney function, typically caused by a disease or condition that impairs your kidneys over a period of time. Type 1 diabetes, type 2 diabetes, recurrent kidney infections. There's several different chronic kidney conditions. The condition is fatal if it develops into end-stage kidney disease without artificial filtering, aka dialysis, or a kidney transplant. We can see in the picture dialysis occurring. They're taking out someone's blood and filtering it artificially before putting it back into their body. Internal cystitis, chronic condition causing bladder pressure, bladder pain, pelvic pain. With interstitial cystitis, signals between the bladder and the brain get mixed up, and you feel like you need to urinate more often than you should, and it's just smaller volumes of urine. So you're peeing a little bit, but you're peeing a little bit a lot with interstitial cystitis. We get perineal pain, painful sex, persistent urgent need to urinate, chronic pelvic pain, or frequent urination. Now, running a urinalysis, there's 2 steps to a urinalysis. The first one is a visual inspection. So we're going to look at the actual urine, see what it looks like. We want to check color because there are some variables that will affect urine color. Diet is a big one. Drugs, medication, disease, all of that can affect the color of urine. And typically the darker the urine, the more concentrated it is. But if the urine looks cloudy, that could be a sign of an infection, or if the urine looks foamy, that could be a sign of an underlying kidney problem. Then we take a dipstick, we can see in the picture, and we dip that into the urine sample. let it sit for just a few seconds, and then match its color to the chart to see where the various elevated levels are. So we can check for pH, protein, sugar, ketones, bilirubins, white blood cells, etc. A whole list of things. And so we can see in our scale here, if we get an abnormal pH level, that's going to be indicative of a urinary tract infection. If we get proteins in the urine, then we're going to think it's kidney problems. If we get sugar, glucose specifically, we're going to think diabetes type 2. If we get ketones, we're thinking diabetes type 1. If we get bilirubin, we're thinking this is liver disease or liver damage. If we get white blood cells in our urine, we're thinking infection because it's white blood cells. Nitrites, we're going to think bacteria. And then blood, we got kidney or blood disorders, bladder stones, or cancer could all be indicative of blood in the urine. All right.